Multiple sclerosis is a relatively common, often quite debilitating disease of the central nervous system. So what might cause multiple sclerosis? Well, we do know it's more common in first-order relatives of sufferers and more common in monozygotic, that is, in identical twins. So, like many diseases, there is some genetic component. And also smoking slightly increases the risk. And it's been known for a long time that multiple sclerosis is more common the nearer the poles of the earth that you live. So it's relatively uncommon at the equator, but gets more common with increasingly northern and indeed increasingly southern latitudes. Which of course is a very interesting observation. So I wonder why it might be less common at the equator and more common towards the poles. Well, it could be that there's some viruses that you get at the poles that you don't get near the equator. Viruses associated with cold weather, for example. That's a possibility. And another possibility is that people that live near the equator, their skin makes more vitamin D. Whereas if you live up in the northern latitudes, then for much of the year your skin is not exposed to any sunlight and we don't make the vitamin D. So it could well be that it's vitamin D that's being protective. Now if that does turn out to be the case, of course, that means we could prevent a lot of multiple sclerosis by giving vitamin D tablets, but we don't know that yet. There's no trial evidence to prove that. But it's certainly an interesting idea. So really the cause of multiple sclerosis, all the smart money now says that it's an autoimmune disorder. People have ummed and ahed about the cause of multiple sclerosis for years, but now it does look like it's autoimmune. And activated T cells have been associated with some areas of demyelination in the nervous system. And if it's activated T cells, it means it's probably the type 4 hypersensitivity reaction. So autoimmune, yeah, almost certainly. Multiple sclerosis is almost certainly going to turn out to be classified as an autoimmune disease. And as we said, relatively common. About 1 in 800 people in the UK have got multiple sclerosis. Over 50,000 people are affected. And it's a problem because the onset is very often in young adult life. The onset is usually 20 to 40. So these people can live for many, many years after diagnosis, which is good, but often with progressive immobility and morbidity. It's a cause of chronic morbidity. It's one of those diseases that's got a relatively low incidence, that is a relatively low number of new cases per year, but a high prevalence. And the prevalence is the number of cases at any one time. So relatively low incidence, thankfully, but relatively high prevalence because these patients carry on living for many years after diagnosis. It's a little more common in women than men, but I've no idea why that is the case. So what's going wrong pathologically in people with multiple sclerosis? Well, the old-fashioned name for multiple sclerosis was disseminated sclerosis. And sclerosis means hardening, because at post-mortem there was many diffuse, disseminated areas of hardening in the central nervous system, areas of gliosis, and gliosis is the scar of the nervous system. And it was noted that these plaques are restricted to the central nervous system and the optic nerves. And we now know that this is because multiple sclerosis is an inflammatory disease of the oligodendrocytes. Now, you remember that round about nerve fibres there are myelin sheaths. And these myelin sheaths are made of individual cells. In the peripheral nervous system, the myelin sheath is composed of Schwann cells. In the central nervous system, the myelin sheath is composed of oligodendrocytes, a form of glial supportive tissue. Oligodendrocytes or oligodendroglial cells. And what these myelin-forming cells do is they produce this fatty myelin which surrounds the nerve fibres. And the myelin insulates, protects and nourishes the nerve fibres, and it also facilitates rapid saltatory nervous transmission. So this myelin sheath is absolutely vital. And in multiple sclerosis there is an apparent autoimmune reaction causing inflammation and subsequent destruction of the myelin sheath, resulting in areas of demyelination. So there's an area of demyelination, and this causes a relapse. The clinical features of multiple sclerosis present. But because the plaques occur at different times and in different parts of the central nervous system, the classical feature in multiple sclerosis is that there are neurological features separated by space and time. Separated by space means they occur in different parts of the body. So one year a foot might be affected, the next year it might be a hand that's affected, the year after that it might be a side of the face that's affected. The lesions vary in space. Different times, different parts of the body affected. Lesions that vary in times and space in the nervous system give rise to corresponding clinical features in the parts of the body that area of the central nervous system represents. Now, after an inflammatory episode, there can be some recovery of the myelin, and the patient very often goes into remission. The disease remits. So the classic pattern is that there's areas of relapse followed by remission, relapse followed by remission, relapse followed by remission. It's a relapsing and remitting disease in the vast majority of cases. But over time there is phagocytosis and degeneration of the myelin sheath, of the oligodendrocytes. And when the oligodendrocytes die, the myelin dies, and many of the axons will die. They can't survive without their myelin sheaths. So you do get progressive loss of axons and dendrites within the central nervous system. You do get areas of gliosis forming chronic plaques. So even though the disease relapses and remits, it tends to get progressively worse over time. It's relapsing and remitting, but the overall pattern is usually to progressive, accumulative loss of motor and sensory function. And this is one of the things about multiple sclerosis. It can affect motor and sensory functions of the central nervous system. Now, classically, three forms are described. The relapsing and remitting that we've just described accounts for 90% or more of cases. But some unfortunate people get what's called primary progressive disease. And this means that from when they get the first symptoms of the disease, they do nothing but get worse. There's no improvements. The disease doesn't remit, it just gets worse and worse and worse with a continuing downward line. That's primary progressive. But then you get some people that relapse and remit for a period of time and then go on to a chronic downward line, a chronic progression of the disease. These people are called secondary progressors. So relapsing and remitting is most common. Some unfortunate people do get primary progressive disease, and secondary progressive disease can also occur. And I've certainly looked after relatively young people in their early 30s, basically completely paralysed as a result of primary progressive multiple sclerosis. But thankfully, that is a relatively rare presentation. Now, we did mention that as well as affecting the brain and the spinal cord, which of course is the central nervous system, multiple sclerosis can also affect the optic nerves. And many people can first present with what's called retrobulbar neuritis, inflammation in the nerves behind the eye, giving rise to blurred vision and even areas of visual loss, and there can be pain associated with eye movements. But thankfully this normally recovers. Other features are fatigue and progressive paralysis and weakness in muscles. So there's a paresis to begin with, there's muscular weakness, and eventually this can effectively become a paralysis of muscles. And this can be associated with spasticity, where one muscle goes tight in an antagonistic pair and the other muscle doesn't. and that can give rise to muscle cramps, even though the condition is not really painful in its own right. It can give rise to painful cramps. There's often a hyperreflexia as well in the early stages of the disease. So progressive limb weakness giving rise to progressive paresis and paralysis. And then there are sensory disturbances. This means that sometimes there's areas of the body that the patient simply can't feel, or areas of the body that don't feel right. There can be tingling, there can be burning pains, even sometimes electric type pains in these areas of sensory loss. And as well as that, as there's progressive sensory loss, then you need the feedback from sensation to have normal movement. So the paralysis caused by motor involvement is made worse by the fact that the patients often can't feel their limbs properly, so they don't get the feedback. And this is going to give rise to ataxia, unsteady walking. Eventually the ability to walk might be lost altogether. And many of these patients become restricted to wheelchairs over time. Thankfully, in many patients, the disease progresses very, very slowly. So I mentioned earlier that I've seen patients completely paralysed in their early 30s with multiple sclerosis. But I've also seen patients in their mid-60s who've had multiple sclerosis for maybe 40 years and still walk, maybe with the aid of a stick. So it's got a very variable prognosis, very variable evolution, and thankfully many patients do maintain relatively good mobility and a relatively good standard of life for many decades, which is great. Bladder disturbances occur, slurred speech, and is there some intellectual interference in multiple sclerosis? Probably a little bit. It's not a dementia by any means, but there can certainly be affective disturbances, mood disturbances associated with it. There can certainly be nausea, especially in the early stages. These patients can be awfully nauseated, which can induce vomit as well. Impotence, unfortunately, is a side effect where the men suffering from it are unable to gain a normal erection. But a very variable evolution of the condition, and life expectancy can easily be 30 or 40 years after diagnosis. So the diagnosis itself is made on clinical grounds, and also MRI it's very easy to see the lesions on MRI scanning these days. And if you look in the cerebrospinal fluid, there can be inflammatory cells, increased proteins and immunoglobulins, again indicating the autoimmune nature of the disease. So typical clinical picture, MRI scanning and cerebrospinal fluid examination. So we're dealing with a long-term disease causing weakness and paralysis, reduced mobility. And these patients are therefore a very significant nursing challenge. There's many things that they are unable to do for themselves that they need help with. They need help with many of these activities of daily living. And if the patients are paralysed, then that's going to include pretty well everything. All the activities of daily living need to be accounted for, as indeed do the complications of immobility. So these patients are going to be more prone to pressure sore formation, for example. I have seen horrendous pressure sores in patients with multiple sclerosis. We really need to prevent this because they can take years to heal otherwise. Pneumonia, hypostatic pneumonia is going to be a problem. Urinary tract infections are going to be a problem. Continence is a problem. Feeding is a problem. Psychological status is a problem. These patients really need quite close nursing care and a lot of support over many, many years. So they really are quite a nursing challenge. Now, what about pharmacological management? Well, ACTH can be used for several weeks. It's a steroid, adrenocorticotropic hormone, and that can help to reduce the inflammation. Methylprednisolone is one of the classic steroids used intravenously. It can be used over 3 days, and the patients can often feel better because it's reducing the inflammation. And other steroids can be used as well. But although the steroids can make the patients feel better in the short term, use of steroids does not affect the long-term evolution of the disease. Now, you would sort of expect it to, really, because I've said that the disease is caused by inflammation. So you would expect that if you suppress that inflammation using steroids, and of course steroids are massively anti-inflammatory, if you suppress that, you would expect the evolution to be improved. But it isn't, it just makes the patient feel better at the time. And other immunomodulating drugs like beta interferon can reduce the attack rate by about a third and reduce the number of lesions. So beta interferon can be effective at reducing the relapses. But again, there's no real evidence that it's altering the long-term evolution of the disease. In 10 or 20 years' time, the patient is probably going to be just as debilitated if they didn't get the beta interferon. But it can improve quality of life for a period of time. But of course, it's horrendously expensive, so most of the world's population don't have access to interferon. On a day-to-day basis, baclofen and other muscle-relaxing drugs are quite useful. Baclofen just takes away the muscle spasm and can take away some of the pain and make the patients feel more comfortable. There's a debate, of course, as to whether cannabis does the same thing. Cannabis is a muscle relaxant, it's also an antiemetic, and sickness can be quite a problem in these patients. So quite a lot of patients do claim benefit from exposure to cannabis. What we really need to do, and what is being done now, is we need to get the clever pharmacologists to work out which parts of the cannabis plant are antiemetic, which parts of the cannabis plant are antispasmodic, and to isolate those. Because people that use cannabis get a kind of, well, it's almost like a form of simple schizophrenia, really. They become very boring people, that's for sure. But if the patients get short-term benefit from it, then so be it, I guess. So general measures: prevent the complications of immobility, physiotherapy, both active and passive. Keep these patients as active as you can for as long as you can. Get our colleagues, the occupational therapists, in. The occupational therapists play an absolutely key role in multiple sclerosis because they can advise on motility aids and special knives and forks and non-slip pads to put plates on and handrails around about the house and all sorts of other things that non-specialists wouldn't think of. So always get your physios in, always get your OTs in to help. My thinking is I always need all the help I can get. If these people are going to help us, welcome them with open arms. More of a nursing observation: these patients are prone to intercurrent infections, UTI, respiratory infections. So have a high index of suspicion for that, and if an infection does present, then treat it early to prevent it developing. And be honest with these patients. And be honest with these patients. And be honest with these patients.